Good evening, everyone. Welcome to this interview session organized by Physician Pathways. My name is Aman, and I'm one, and my host here is Aaron. Tonight we have a special guest, Kara's a brother, actually, Dr. Michael Ingram, a PG5 vascular surgery resident at Indiana University. We'll be asking Dr. Ingram about his medical journey and career as a physician before finishing up with any questions attendees may have. Without further ado, thank you, Dr. Ingram, for being here with us. Can you start by describing your medical journey and where you attended medical school?
All right, sorry about that. Yeah, absolutely. So I attended medical school at New York Medical College. It's a school just outside of New York City, in Valhalla, New York, and started there now, 9 years ago. So it's getting to be a while. But ended up there after going to undergrad on the East Coast as well at Middlebury College in Vermont, and originally from the Chicago suburbs. So wanted to come back to the Midwest for residency.
Perfect. And just to get into it a little bit, what should us as medical students know about surgical residency and maybe vascular surgery in general?
Yeah. So I think that you should certainly know that it's difficult. It's a tough field. It'll be a difficult residency, but it's maybe not as bad as it's always cracked up to be. I feel like people always scare you into saying that it's this truly like terrible thing that you'll never be able to have fun. I still have a lot of fun. Able to go out with friends, see friends at work, have a good time there, have a good time outside of work, still go on vacation. You'll be busy at residence during your day, pretty much any surgical field. And that's just because you're doing your residency for 4, 5, 6, 7 years, and you have to learn to be a good surgeon then. So the onus is on you then. So I guess I would expect long but not impossible hours. Schedule's probably a bit more hectic and chaotic than some other specialties. Vascular surgery itself has a fair amount of call involved in it. So it can be busy, but it's still fun, and you still have a life. I still see my wife, who's also in medicine. She's in pediatrics and this pediatric subspecialty, and they work just as much. So regardless, residency is going to be tough, but not impossible.
And then could you go into describing a little bit about some of the common procedures that you do on a daily basis?
Wow, yes, how perfect. So I actually prepared, that's most of this brief PowerPoint that I made here, because I feel most of vascular surgery is you have to see kind of pictures in order, if you're not familiar with it, which I never heard of vascular surgery really until my third year of medical school. I saw it on my general surgery clerkship. We covered a variety of different surgical subspecialties on that. And that's really where I first truly discovered it. So vascular surgery is basically surgery on all the arteries and veins, except for the heart and brain. Those have their own subspecialties. So ultimately, it can usually be dumbed down to basically we do some bloody plumbing. So in terms of our common cases, what a really unique thing about vascular surgery, I think, is that we bring a couple different techniques to the table. So there's always your open, or what's more known as the traditional surgical approach. That's where you make a direct incision on the skin, find whatever pathology you're working with and directly address it there for like direct visualization. And then there's endovascular approach, which is basically you're making an arterial puncture somewhere on the body and using angiography, basically contrast dye injected into the arteries or veins, and then X-ray fluoroscopy and catheters and wires and balloons and multiple different devices in order to address that pathology. So that's a more minimally invasive approach. Always has its pluses and minuses. And then what vascular surgeons can offer is a hybrid approach. So a patient with a certain pathology, if you think part of it would be best addressed by a stent, but then they also need an open exposure, the vascular surgeon's able to do both. So a variety of vascular surgeons work all over the body. So starting at the top, the highest we generally go is the neck. So we perform an open carotid endarterectomy. So this is patients who present with stenosis or near occlusion of the carotid artery, often have strokes or TIAs. And we, in the middle picture there, right under the 2C label is the carotid artery. We basically go in, remove the plaque, and then suture a patch onto the top of it. And that will prevent embolization from that plaque. The other option that's relatively new is you can do a transcervical carotid artery stenting or transcervical carotid artery revascularization, commonly known as TCAR, and essentially directly access the neck. This device kind of in the middle is actually a flow reversal system, so it helps protect from stroke, and it filters out debris and returns the blood back to the femoral vein. So that's a pretty interesting technique, but where you're able to offer patients either the open approach or the stent approach. They both have their pluses and minuses. Again, another common operation we deal with is working with usually abdominal aortic aneurysms, although the aneurysms, as this picture with the stents demonstrates, can be pretty much anywhere in the aorta. So you see the open bifurcated graft, that's a big laparotomy incision down the midline of the abdomen. You resect the aneurysmal portion and sew in a prosthetic graft. Or on the screen right is a bunch of different grafts that you can place in the aneurysm. And the technology is ever advancing. You used to not be able to put any of these fenestrations or basically like the grafts off the graft, all the different bifurcations to the different visceral vessels. But now things are getting really complex. You're able to fix a lot endovascularly. These sometimes have durability issues and require more monitoring, so they're not right for everyone. But again, you get to tailor your operation. And then another really common disease that we work with is lower extremity occlusive disease. So just like people need heart bypasses, people need leg bypasses. So it's you can do a big open operation where essentially you open up all of the leg, use either the patient's own vein or a prosthetic, and connect above the blockage and connect below the blockage to restore perfusion. You can also do an endovascular approach with angiograms. And then this is it's a busy graphic, just shamelessly stolen from Google, but essentially there are so much technology that's being created and utilized now, but basically all stems from that minimally invasive approach using balloons, catheters, suction devices to remove clots, like rotational atherectomy, which is essentially just a roto-rooter to clear out. None of it's perfect, all has its pluses and minuses, but again, capable of doing it all. And then a bread and butter operation is your hemodialysis access, creating AV fistulas for patients in order to dialyze through. A nice open surgery, relatively quick surgery with decent outcomes. And then all that's arterial work. There's also a wide range of venous pathology that you can work with. And that angiogram is a pulmonary embolism where the operator used a suction catheter basically to remove all of that blood clot that's on that blue clot from someone's lung and able to restore perfusion, as you can see there. And then on the smaller, a little bit less stressful scale, there you can also do varicose vein treatment for patients. Usually there's medical reasons and then cosmetic reasons, but they may have some wounds or swelling or pain that requires their veins to be treated. That's the most of my the pictures that I needed. So I'll stop sharing my screen and I'll let you guys ask whichever questions you had prepared.
That's a perfect transition. I wanted to ask you a little bit about your decision-making process in terms of vascular surgery. Did you always know you wanted to go into that specialty, or was there a decision between a couple options?
Yeah. So no, I did not always know I wanted to go into vascular surgery. I always knew I was leaning towards a surgical field. Never really knew exactly what. My first couple of years of med school, and before that, I thought I wanted to do orthopedic surgery. And then I experienced that after my M1 year, did some research and shadowing in it for that whole summer, and really found that I didn't enjoy it as much as I thought. I didn't find the pathology to be that interesting. I think I liked something a little bit more detailed. So what was the rest of the question? How did I get into vascular? Or
Yeah, I guess like going off of that, like, did you have an aha moment, or was this like a gradual process where you just became more and more interested in the specialty?
Yeah, I guess there probably was an aha moment. Like I said, during my third year clerkship, we had to give lectures to some of the faculty and other medical students on rotation. And one of my co-fellow or co-med students presented on EVAR, which is endovascular aneurysm repair, which is that stent that I showed you, and went into like a lot of detail with it. And I just thought it was really cool. The fact that you could fix this massive problem, which in open aortic repair is a very morbid operation. And the fact that you could do this now without such a big case was really cool. I was debating whether I wanted to, if I wasn't going to do surgery, I actually really liked pediatrics, which is not always the debates that some people have. But I had my peds rotation later in my third year, and surgery before, and I really liked surgery. And about halfway through the peds rotation, I realized it was like late in the afternoon. We were rounding, it had been rounding like all week, that I just couldn't round all day. And so that was the dichotomy. Obviously not all, a lot of residency is rounding. Obviously you can tailor your non-surgical field to not be rounding all day. But that was kind of what sealed the deal for me there.
Additionally, I was just wondering, like, what is the hardest part of being a vascular surgeon, and are there any like skills you have developed through your years of training?
Yeah. So there's a couple different ways, I guess. Maybe the hardest that I'm coming to realize at least at this point in my training is how you deal with complications. Surgery itself is not perfect, and then vascular surgery itself, a lot of our operations frequently have complications, either because of patient factors or just the fact that it's what we do is generally works, but they're not perfect. So kind of how you learn to kind of cope with that and deal with that has been tough, and I don't know, still trying to figure it out. In terms of like the technical aspect, like I said, that we do operations kind of all over the body. So just learning anatomy for basically, we do literally from skull base to toes, and you can be doing those cases, multiple different exposures all day. So learning the anatomy has been really important and part of it, like a challenging portion. The technical skills are also difficult, but that sort of just comes with practice. That fairly confidently anyone can learn with enough practice.
And then pivoting just a little bit, what would you recommend for students interested maybe in pursuing a surgical specialty that they could do now to become a competitive residency applicant down the line?
Yeah, I would definitely recommend trying to one, get exposure, like a reasonable exposure to that field. Obvious, like how I did with orthopedic surgery. I was fortunate. I had, I don't know, some time off between my first and second year in the summer, and was able to shadow and see what that was like. So trying to get involved within the department of what you think you're in. Obviously, everyone always says that you have to do research or whatnot. I don't necessarily think that like research is important so that you check some boxes, but like if you're not passionate about it, I don't know that you like really have to seek out research. There's other ways that you can, I think getting involved and exposing yourself to the field, and research often provides kind of an easy access point for that in order to meet different attendings or residents or fellows. I think like reaching out to the department of whatever you're interested in is a good place to start. And then if they allow like a shadowing opportunity to start there, and then discussing if they have any projects that they need help with, if that's something that you're interested in, or kind of going from there. But otherwise, obviously, a lot of surgical subspecialties are competitive, so you have to get good grades. I know test scores aren't as important, so I honestly don't know how that's going to differentiate things. I'm sure a lot of people are probably telling you guys that too, but doing well in school is important. So.
In a related vein, I was just wondering what made you rank Indiana University's program above others? Like, what are the type of things that you were looking for in a program, especially since you're looking at, at a surgical specialty?
Yeah, quite a few things went into the rank list. First off, I couples matched with my wife, now wife. So figuring out a place that would be a good spot for both of us, and making sure that that was high on the rank list. And she also wanted to do a pediatric subspecialty, so offer a place that would offer a good fellowship for that, so she wouldn't have to leave after 3 years. But in terms of my surgical program, one, you might hear about programs that are malignant, or that treat each other poorly is kind of how I would define that. I wanted to avoid places like that. So I wanted to be somewhere where residents got along well with each other, where they had like a very collegial, friendly atmosphere, where the attendings treated the residents with respect, where I would have a good surgical training. Like residency, you want to see all the really hard stuff, so you know how to deal with it when you're out by yourself or with less supervision. And then also wanted to be like my field. I knew my program was 7 years, so that's really almost the longest, besides my childhood home. That's the longest that I've ever lived anywhere in a long time. So I wanted to make sure I was in a place that I actually enjoyed being. So Indiana fit the bill, and so we ranked it one of our top choices. That's where we ended up.
Do you mind talking about the couples match process a little bit? Because I don't really know how it works at all.
Yeah, absolutely. I'm assuming, I haven't heard that it's changed majorly. So since we did it 5 years ago, essentially you decide that you want a couples match. Anyone can decide how to couples match. Usually it's people in a romantic relationship, but any two people in the NRMP can decide that they want to go together as a couples package. And essentially it works very similar to the just regular traditional match process, except when you submit your list, you submit basically a combined list. So for like my wife would on our list, and you submit it the same for each of us, we both list like Indiana number one for under both of our names. And then as you get farther down your list, if you don't have as many places together, then you can switch it up and see like if you weren't going to be here, where would I want to go? And then they run their computer program, and the match generally is set to favor the applicants. So if Indiana ranked us high, then we would end up at Indiana. If they didn't rank us, we technically were ranked Michigan first. Indiana, I think, was our fourth choice. But Michigan for either ranked someone else higher. So then we moved down our list to Indiana. And it basically just tries to figure out the highest combination of where you've been matched and where you've ranked. In terms of like the actual interviews and gaming it almost was sort of beneficial in getting more interviews. If your significant other, whoever your couple's matching with, gets an interview, it's often encouraged for you to reach out to that program and say, hey, my partner in this program is being interviewed. We're very interested here. Would you consider looking at my application again? And we each got a couple interviews that way. Anecdotally, I've also heard that program directors like when people's couples match, because it provides you with the built-in support system that you'll come with. A lot of people are moving to their residency not really knowing anyone in that city, and it can be lonely in the beginning. So it's nice to have someone that you know that's traveling with you.
I guess looking back, is there anything you wish you had done differently when you were a medical student? In terms of like extracurriculars or just schoolwork, things in general?
Yes, but it's gonna be bad. I'm gonna be a bad influence. I wish that there were those nights where I was staying up just kind of like staring at my notes at like 11 p.m. or whatever after I'd been studying all night and realizing that nothing is sticking in my head. Like, like go hang out with your friends for an hour, take a breather. It'll be okay. Cause I don't think I realized it later in my medical school career, probably like towards the end of my second year, that you're allowed to leave the library. And my scores I think I actually did better when I started relaxing a little bit more and realized that there is a limit to how much that you can study and read, and before stuff just stops sticking. So that's my bad influence. Sorry.
And then a little bit more of a focus back on your career, kind of a fun question. What is like your favorite part of your job? And then maybe what is your not so favorite part of your job?
Yeah. I'd still say my favorite part is operating. That's something that you have to, obviously, if you want to be a surgeon, you have to like to operate. So I still find joy. Sometimes, you go into a case, know it's going to be a long case, know you're going to get out late and have a little bit of sense of dread. But once you get into the thick of it, I really enjoy kind of the technical aspect and decision making that goes on intraoperative. And then something that I don't enjoy, probably you'll probably get unpleasant patients in every field. I don't think that's unique to vascular surgery, but vascular surgery seems to have a fair amount of people who have made poor health choices their whole life, and then you have to deliver some bad news that they need surgery or something like that. And they're like, how could this happen to me? And it's like, well, you haven't controlled your diabetes for 30 years. You've been smoking, even though everyone's told you to stop. And so that's not always so pleasant, but I think you'll get that in probably every single field in medicine. So.
One question that just popped into my head, and I think we're about almost done here, but you mentioned that you did orthopedic surgery, like research during medical school. Did you do any vascular surgery research in particular, or not really?
No, well, I did one basically like case report poster presentation from our school, just put on like it was really just like the Department of Surgery hosted a research day. So relatively like low barrier to entry. If you submitted something, I think they accepted it. And I presented on that. And then I did like a little bit of work on a project, like basically doing some chart review. I was like a middle author on like a low grade publication. It gives you something to talk about. Like people will always ask you during interviews, like what is something that you're involved in, and that gives you something. I don't think they don't really care like where it was published or kind of like, did you write the manuscript? They know that you're kind of at the bottom of the totem pole and still trying to learn about the field and don't really have all the insight to ask the questions, to write the paper, etc. So yeah, I did, but I got involved with it, like I said, pretty late. So, but it worked out okay.
And then I have one more question for you before we open it up to the audience. But how do you balance your life and your work with obviously being a vascular surgeon? I know that's like can be very demanding. Your wife is also a doctor, so I was just wondering if there's any specific thing that you do to make sure that you have like a life outside of work.
Yeah, I, for the most part, try to leave my work at work. I try not to do any, obviously, I think it's unavoidable to not do anything at home, but I try not to like write notes at home. I do my studying and reading up on what I'm going to be doing, but not like the busy work of work. And then I do try to just get out and do things not at the hospital. Just like either I like taking my dog for a walk every day, exercising every day, and then seeing friends on the weekend, trying to stay busy, do things around the city, and being intentional about that. Because I think no matter what your residency is, you'll be tired at different points. Some points more so than others. And to me, it's important to make myself kind of get out and live my life rather than just kind of sleep all the time, which some people like. I like to stay busy.
Awesome. That was great advice. So before we end here, does anyone in the audience have any questions you'd like to ask? You can just unmute yourself or put it in the chat if you would like.
One big thing that I did want to mention at least is that vascular surgery has two major pathways to get there. So you can apply in an integrated residency program, which means that you apply straight from medical school. You do, it's called a 0+5 program because you don't do any you do general surgery rotations, but your training is all dedicated towards vascular surgery. So you usually do about 24 months of general surgery rotations and then 36 months of vascular surgery rotations. The alternative is what they call a 5+2 program. And that's where you do a whole 5 years of general surgery residency and then apply for a vascular surgery fellowship, which is an additional 2 years of training. So if you decide late, that's something to do. There's pluses and minuses to each field. If anyone actually has any specific questions about it, I'd be happy to talk about it now or later. You guys are welcome to email me or reach out whenever. So, but that is a key point. A couple of plastic surgery and cardiothoracic surgery both have those different options too. So I wasn't aware of that certainly when I was in M1. So.
All right. Well, thank you so much for that. That was very helpful. I'm glad that you added that because I had no idea that was a thing.
Yeah.
So if no one has any other questions, we will end here. But again, thank you so much, Dr. Ingram, for coming. This was very informative and I learned a lot. So thanks.
Yeah. Thank you for having me. Appreciate it.
Thanks, Michael.